The major pitfalls are conventional versus LBC learning curve, LBC morphology pitfalls for the correct diagnosis of squamous and glandular lesions, short breadth versus thin breadth system-specific pitfalls in morphology, and lookalikes. So let's just start with conventional versus LBC learning curve. Let's go back to basics with the normal cells. The normal squamous cells in LBC, because of good preservation, start showing the folding in the nuclear membrane a lot more. And you can see the normal mitosis as well. So please do not make the diagnosis of abnormal cells with these findings. Endocervical cell, now you see a lot more single endocervical cells. And you need to learn to make the diagnosis of abnormality in a single cell. You see a lot more cilia now. And please do not make the diagnosis of TEM on that. And for endometrial cells, the degenerate endometrial cells with top hat appearance in conventional is not seen as much. Instead, we see very intact, non-degenerate endometrial cells with three-dimensionality. And this is the most error of calling false positive error, calling them abnormal cells in a normal endometrial cell as high cell. So following negative or normal cases were wrongly called ASCUS during learning curve. Reactive metaplastic cells. Reactive metaplastic cells with crenated and folded nuclear membrane. Squamous pearls with slight nuclear enlargement. Dyskeratosis without nuclear abnormality. Trichomonas infection or other infection with inflammation with nuclear enlargement were wrongly called ASCUS or SIL. Word of caution, especially for this error, a lot of nuclear overlapping is seen now in LBC, which gives the false impression of nuclear enlargement with chromatin abnormality. So learn to focus and use high power more often. Times 20 is very important. The next one is LBC morphology pitfalls for the correct diagnosis of squamous and glandular lesions. For definition of SIL, abnormal chromatin pattern and distribution. Distribution is extremely important, are essential requirement. So every time when you are screening, try to just imagine and divide the nucleus in 4 quadrants and see the chromatin distribution in each quadrant. If it's unevenly distributed, unequal distribution means SIL. As you can see when you are screening this slide, just try to think in your mind, dividing it into 4 quadrants and see the chromatin distribution. If it's unequal, it's SIL. You can see in this picture, the top one has got abnormal chromatins, fine, speckle, or coarse granularity, but evenly distributed chromatin. It means it's not SIL. However, the same nuclei and same chromatin pattern, when abnormal chromatin, irregularly distributed chromatin, it means it's SIL. Chromasia. Chromasia can be hypo or hyperchromasia. So even hypochromatic nucleus can be SIL, and try to see again chromatin distribution irregularity in that. If it's irregular, then it's SIL. Following SIL cases were wrongly called ASCUS during learning curve. The indented nucleus, those SIL with indented nucleus was called ASCUS, while it is SIL with abnormal chromatin pattern. The slight irregularity of nuclear membrane, hyperchromasia and irregular chromatin distribution, this is SIL. Hypochromasia, and still abnormal chromatin distribution is SIL. So let's just see. These are the two images. Which one is SIL and which one is negative? One in here, although there's a regular similar size nucleus, but abnormal chromatin distribution, so it's high SIL with the size of the nucleus. This one looks very similar, but because of overlapping of the cell, it gives false impression of abnormal chromatin distribution, but abnormal is very regularly distributed. So this is reactive changes, not SIL. To learn the grassroots morphology in LBC, otherwise interpretation errors will be killer. The next one is the major pitfall in show path versus thin prep system-specific pitfall. Hyperchromatic crowded groups in show path and immature metaplastic cells in thin prep. So hyperchromatic crowded group always focus, if it's three-dimensional, chaotic architecture, and then pleomorphic nuclei, when you can see, then examine the chromatin distribution abnormalities. All three are present, it's abnormal. Next to it, the normal endocervical cell, negative, hyperchromatic, crowded, but not flat, not three-dimensional, non-chaotic architecture, and nuclei hasn't got the chromatin distribution abnormality. So normal, abnormal. What about metaplastic versus high SIL in thin prep? When the hyperchromatic crowded group metaplastic with thickened nuclear membrane, prominent nucleolus, and evenly distributed chromatin, it's a reactive metaplastic negative. So let's just examine this image. Is this metaplastic normal or high SIL? Here, the top one has got thickened membrane nucleolus and no chromatin abnormality, that's normal. But at the same time, there are abnormals with no thickened membrane, no nucleolus, and abnormal chromatin. So word of caution, abnormal cells infiltrating the crypts can have normal and abnormal cells in one cluster. So please examine carefully the cluster. Now, pitfalls in squamous cell carcinoma. The differential diagnosis of large cell non-keratinizing carcinoma is repair cell and endocervical adenocarcinoma. Repair has got polarity maintained within the hyperchromatic group, crowded group. Invasive squamous carcinoma has loss of polarity. That's the most important differentiating marker. So these two images, polarity is maintained, loss of polarity. This is repair, negative, and this is cancer, invasive carcinoma. Other differential diagnosis is squamous cell carcinoma versus endocervical adenocarcinoma. In endocervical adenocarcinoma, features of AIS are still present, as you can see the AIS here. And so this is endocervical adenocarcinoma. What about diathesis? Diathesis can be tumor diathesis or benign diathesis. In tumor diathesis, the malignant cells are present in the necrotic debris. In benign diathesis, which can occur due to atrophy or inflammation, trichomonas infection, there is the inflammatory dirty background, but no malignant cell in the diathesis. So compare these two, malignant cells and no malignant cells in the debris. So this is tumor diathesis and this is benign, non-malignant. What about nucleoli? Malignant nucleoli versus reactive nucleoli. Malignant nucleoli have windowing and also large abnormal with windowing, and the nucleolus are more often red nucleolus. Differential diagnosis of small cell squamous cell carcinoma. It can be normal and abnormal endometrial cells, lymphoid lesion, small cell high cell, or reserve cell hyperplasia. As you can see here, follicular cervicitis, normal parabasal, normal endometrial, normal histiocytes, pair staining high cell, and ask H because you cannot see chromatin here. So normal to abnormal up to the squamous cell or high cell can give rise to those small cells, and examine them carefully. What about keratinizing squamous cell carcinoma? The keratinizing squamous cell carcinoma has got a keratinized cell which are tadpole or corded cells, but similar type of keratinizing cells can be present in atypical parakeratosis and dyskeratosis with or without tumor, and also in wart condyloma and keratinizing SIN. But also, keratinizing squamous cell carcinoma, you can give false negative result when the tumor is infected or ulcerated, or malignant cells are scanty, or in verrucous carcinoma. So verrucous is a rare tumor, it's an exophytic tumor. And so what you get in the smear are all these keratin, and very scanty cell which may not be present. Okay, so now let's go into looking lookalikes. The problem with small cells. All these things giving are small cells. Some are negative, some are cancer. So histiocyte, immature metaplastic, follicular cervicitis, and endometrials, they can all give small cell and difficult to differentiate with the small cell or cancer. Crowded cell groups. These are all crowded. Some are negative, some are abnormal or cancer. These are negative reactive metaplastic, normal endometrial, while this is high cell abnormal. What about irregular nuclear membrane? Irregular nuclear membrane, when the normal metaplastics, now in LBC, you can see them so well, that irregularity of nuclear membrane we see, and still this is normal. While high cell has got no irregular nuclear membrane, but the chromatin distribution irregularity is present here. So with high cell, there is no chromatin distribution irregularity. It is negative. Cells with large pale nuclei. And those large pale nuclei again can be present in normal and abnormal cells. These are reactive normal endocervical cell. This is squamous carcinoma. And also, you can see that these are all abnormal and this is normal. Multinucleated cells. Multinucleated cells can be present in adenocarcinoma, in cancer, histiocytes, herpes infection can be, as you know, the multinucleate cell with the ground glass appearance, and normal endocervicals can give the multinucleated cells. Cells with dark nuclei. So dark nuclei may be due to degeneration, but high cell and ASK-H can also give those type of this small cell, while the degenerate endometrial is the other condition where the small cells are present. Bare nuclei. Bare nuclei can be present negative here, no chromatin abnormality in atrophy, endocervical negative nuclei, high cell with chromatin abnormality when you divide into 4, so abnormal, and the tamoxifen therapy in breast cancer also give a lot of bare nuclei. Few glandular abnormality look alike. Tubal metaplasia versus glandular neoplasia. In tubal metaplasia, the crowded cuboidal columnar cell with cilia may or may not be present. The important thing in endocervical adenocarcinoma, the small strips can have sharp cytoplasmic community border. That's important. So this is a sharp cytoplasmic community border. This is glandular neoplasia. while this one has got no sharp border. It's humpy and cilia. So this is tuboendometrial metaplasia, negative. And even without cilia, you can see that it's humpy. And so it's negative tuboendometrial metaplasia or tubal metaplasia. Endometrial cell. And be very careful because they are very well preserved now. And the endometrial adenocarcinoma versus the bubblegum cell, IUCD changes negative. And the one last but not the least, the important one, post-radiotherapy changes versus atypia of atrophy. So this type of the large cell after radiotherapy can get a false positive diagnosis of recurrence of tumor, but the smudgy chromatin is clue for the correct diagnosis of negative atypia of atrophy. The last one, the test time. I was going to show you first the image. They both look so similar. However, this is small cell carcinoma and these are just normal endometrial cells. So, trying for impossible? No, you can do it if you know your basic